Monitoring. All of our patients will have a basic data set on the monitor, real-time information that you can use. This is an actual patient's data. There's no name on it. And what you're seeing is an actual set of data from a real patient. What we have is what you will typically have in intensive care. 3 lead ECG traces to run your rhythm strips, an arterial line, saturations, CVP, and end tidal. So everybody knows what a decent heart rate is. As you can see, coming back from the chat the doctors had, this particular patient is running a heart rate of 50. The monitors are not alarming because the doctors have told us that they are not concerned about that rate because we are achieving our mean target with a rate of 50. So what we have done, the nurses, is turn the alarms down so that it doesn't alarm at 50 because we're quite happy with a heart rate of 50. Normally our alarms will be set at the usual parameters, 60 to 110 for a heart rate, etc. It's very... Now, coming down to the arterial trace, the trace is important. It can be very sharp, it can be very soggy, is the easy way to think of it, over and under damped. Now, sometimes when you look at the arterial line trace, you might say, no, that's too damped. I don't like the look of that. It's not real. Check your patient. There's a tendency sometimes to look at the monitor and believe it. The monitor is not as good as checking your patient. Always confirm what you see by checking your patient. If you've got a flat art line and you think it's because they're taking a blood gas, make sure your patient's still alive. When you take a blood gas, this line will go flat because you're redirecting the flow. Always important, and I'll say it again, to check the data on the monitor against the patient. Saturation's a very useful number. CVP, not a terribly useful number. Doesn't really tell us a great deal, even in the ITU. Useful for trend. What we do have is end tidal, and end tidal is your friend. Not the numbers, the fact that it's going up and down. Because if it's going up and down, they're breathing in and out. So there we have a nice end tidal trace. Patients, we know the patient's ventilating because we've got an end tidal trace. So that's nice to have. Don't look at the number. The number isn't particularly useful except for trend. In terms of setting up these monitors, they should have the patient's name, certain biographical data in them, and then we set up these waveforms as standard. And then we set up alarm settings. Again, they can be adjusted. For example, with this patient, which is a good example, as I've said before, normally we would set the alarms to alarm with a heart rate of 60, but this patient is absolutely fine according to the parameters set by the big brain doctors, the consultant intensivists, because we're achieving our mean with a nice slow rate. So obviously there's no point in having an alarm of 50 because it'd go off all the time. If you hear it alarming, don't ignore it. They alarm a lot. Critical thing, don't ignore it. And what you see on there, if it's alarming, before you silence it, check your patient. Thank you.